My name is Savannah Haverfield. I'm the Community Relations Representative here at University House Issaquah. And before I introduce our presenter, I do want to give you a brief little background on our partnership with the University of Washington School of Pharmacy. And we are very proud of our relationship that we've started with the University of Washington School of Pharmacy since 2011. Through the partnership, UW students and faculty provide a range of non-dispensing pharmacy services at all of our communities. And that includes medication reviews and direct patient and family education, one-on-one appointments, medication consultation with staff and providers, health screenings, emotional support to residents and family members, and educational presentations like the one we are about to hear. And our presenter today is Dr. Abby Winter. She is a licensed pharmacist and clinical assistant professor at the University of Washington School of Pharmacy and serves as Director for Outreach for the Pline Center of Geriatrics. Abby leads the educational, clinical, and outreach efforts for the University of Washington School of Pharmacy at all ERA living communities. And with that, Abby, I will hand it over to you.
Great, thanks so much. I'm going to share my screen here. And while I get that set up, make sure that, oh. Now, Savannah, can you confirm, does this look like a presentation to you right now, or is it just the slides? I think you are muted.
It is not just the slides yet.
Okay, interesting. My apologies. We're all still getting to know how these, all the things with Zoom are working these days. So let's try it one more time. Is this, did that do it?
It's still showing the notes section. I
am so sorry. Give me one more try. I'm going to stop sharing. It worked in our practice, I promise. Thanks for your patience, everyone. Give me just a moment. Well, this is why you practice, right? Even if it doesn't work for you there. I'm going to try one other thing here. And it shows everything over on the right, doesn't it?
It does.
Goodness gracious. I am so sorry, guys. I really do apologize. Let's give this one more try. I'm going to stop sharing and share again one more time. And then I should just be able to say, I think it could be because I have a separate screen up. And it did not happen last time, so we'll hide presenter view. Nope. I really do apologize. I'm going to give it one more shot, and if not, we'll just roll with it how we have it going. I'm going to Savannah or Tina, do you have suggestions on how we could fix this? What if I do that? There we go.
Oh, there you go. It's perfect.
Thank you all for bearing with me through that. And I think that just goes to show we're all human and we've got struggles going through this at this time. But now we're ready to get started. So thanks for hanging in there with me. As Savannah said, my name is Abby Winter. I am a clinical assistant professor at the University of Washington School of Pharmacy. And as she said, I work in outreach primarily with the ERA living communities. So once COVID allows, we'll be having regular visits at all of the communities, and we'll be working with residents and working with staff to kind of enhance the awesome relationship that we have with them to help improve the quality of life and some of the healthcare aspects of the residents at ERA. So with that, we'll get started. Today, the name of the presentation is A Doctor, a Pharmacist, and a Nurse Walk into a Bar. And the reason we pull the bar in is because we're talking about the Beers criteria. So it does not have anything to do with beer or alcohol, which is often a confusing thing for some people when we're talking about medicines. They think, are these medicines that you can't mix with alcohol? But it actually has nothing to do with that. And we'll talk about that in a little bit. But sometimes it's fun to play on those words. But the main thing we'll be talking about today, like I said, is the Beers criteria and then medication use in older adults in general. So today we'll be talking through some general information about medications in older adults. We'll look at the AGS, which is the American Geriatric Society Beers criteria. We'll look at some background, talk about why it matters to you or your family members, and look through some examples of medicines that are on what we call the Beers list. We'll also have some action items talking about what you can do, how you can talk to your prescriber or your healthcare team about your medicines, and then any some additional resources that could be helpful. So first, we'll talk about medication use in older adults. This is a great quote. It's actually from one of the people who is on the panel for the Beers criteria. And she said, medications play an important role in health and well-being for many older people. That's something that we all recognize. But what's important here is, as we're going through a lot of stuff today, I want you to keep this in mind. It might seem like we're saying medicines aren't great or there are a lot of risks and that sort of thing, but it's important to remember that medicines are important. As a pharmacist, of course, I recognize that, but making sure that we keep this at the forefront. So there's a lot going on here, but I want you to look over at this graph, the colorful picture on the right. This is talking about medication consumption. So the National Center for Health Statistics did a survey of older adults and their medications. And based on that survey, they looked at how many medicines patients are taking regularly based on how old they are. So that graph on the right, as we move from left to right, the age increases. So the far left is 20 years old and the far right is 80 years old and older. And then all of the different colors represent how many medicines each of these respondents were on. So the green represents anywhere from 0 to 4 medicines. The yellow is 5 to 10, and then the orange and red is 10 and above. And so what we see in this graph is, as people age, they are on more chronic medications because more of the red, orange, and yellow takes up that graph. About half of the people who responded to this survey, who were over 65, were taking 5 or more medicines every day. And 20% of people aged 65 and older had 5 or more chronic medical conditions. And we know with more medical conditions, often it means more medicines. Another interesting thing we found in this survey was that more than 40% of people who were over age 65 were taking at least one over-the-counter medicine and at least one supplement. So that's something that's interesting because we often think of, if you can buy it over the counter at the pharmacy or it's a supplement or a vitamin, it must be safe. And often that's true, but it's really important to keep in mind that that still counts as a medicine. It still has the chance to cause side effects. It still has the chance to interact with other medicines or other conditions that you have. So we still count those as medicines. As I was saying initially, we need to keep in mind that medications are a mainstay of modern medicine. They're used to help manage a lot of different health conditions. They relieve symptoms you may have, reduce your risk of future problems, or help correct even life-threatening illnesses. But the thing that we'll be talking about a little bit more today is that medicines also come with risks and side effects, which I don't think is anything new to anyone, but it's important to keep that in mind, knowing that we have that balance between the two. One thing I want you to be aware of is a term called polypharmacy. So polypharmacy is not, if you break it down, we're thinking multiple pharmacies. That's not it, it's more medicines. So polypharmacy, the definition is that you're taking 5 or more chronic medications. So chronic means something you take regularly. Let's say you take some Tylenol a couple times a month for a headache. That's not a chronic medication. still something to keep in mind when we're looking through our talk today, but it would not be considered a chronic medication. But what's difficult is more medicines or polypharmacy, so 5 or more medicines, can be associated with adverse health outcomes. So the risk of potential harm increases with each additional medicine that we prescribe or each additional medicine that a patient takes. And some of these adverse health outcomes that we get concerned about, especially in our older adult population, are falls, exhaustion, frailty, cognitive impairment, mortality, and decreased physical function. None of these things sound too intriguing to me. One thing that we're also concerned about as we add more medicines is something called adverse drug events, or ADEs. So adverse drug events are unfavorable or unintended reactions or symptoms that are associated with the use of a medicine. So in other words, it's harm caused by a drug, even if you're using it appropriately and at a normal dose. This is different than a drug side effect. So sometimes you take a medicine and the side effect could be it gives you a cough, or the side effect could be it makes you a little drowsy, or the side effect could be constipation. Side effects are things that we often expect or know are likely to happen from medicines, but adverse drug events are perhaps a little bit more serious, or things that even if you're taking everything correctly, exactly as you're supposed to, we could have some harm that comes from it. So maybe a slight dry cough is not necessarily harm, but something more serious that does cause harm, we would consider an adverse drug event. For example, the things that we mentioned before, like a fall or cognitive impairment. So the 2 new terms that we just talked about, polypharmacy and adverse drug events, how are they related? Polypharmacy, so 5 or more medicines, can often lead to more adverse drug events. And adverse drug events are a threat to the health of older adults, especially because, as we saw in one of those first slides, older adults are taking more medicines, which leads to more possible interactions and problems from their medicines. An interesting fact, about 10% of hospitalizations for older adults are because of adverse drug events, meaning we can trace it back to a medicine or an adverse event from a medicine that's leading to this hospitalization. Management of adverse drug events, it's estimated that it costs the United States over $30 billion per year. That's a little bit scary, but the good news, most adverse drug events are preventable. And that's another thing that we'll talk about today, especially when we talk about how to talk to your doctor about your medicines, what medicines to be aware of. It's helping you be an advocate for yourself to help prevent things like this. In order for any medicine to work effectively, 4 things need to happen. And in the pharmacy world, we call this ADME, A-D-M-E. So drugs need to be absorbed into the body, that's the A. The D is distributed, so they have to move to whatever part of the body they need to go to actually work. They need to be metabolized. So metabolize means it's a chemical change that has to happen with the drug in your body in order for the drug to actually work, or in order for the drug to be eliminated from the body. And then the E is eliminated. Often that's through the urine. So we don't take a drug and then it stays in your system forever. It has to be eliminated. So these 4 things have to happen in order for drugs to work effectively. But different things in anyone's body can affect how well your body does those 4 things that make those drugs work. So the composition of your body with muscle and fat, how your metabolism works, your liver function, your kidney function, other diseases and health conditions, other drugs that you're on, all of those things can affect how well a drug works. And as you could probably see where we're going here, as you age, these changes in our body can also affect how well these medications work, because these examples on the left are all things that do change as we get older. So as we age, what changes are we really concerned about? One is fat distribution. So you might notice as you or your family members age, your fat is distributed a little bit differently in your body. There may be more or less. And there are some medicines that are absorbed in the fat. And so if you have more fat, that drug sticks around a little bit longer and could have action for longer than we want it to. Your liver function can also change. Often the change is that there's a decrease in blood flow to the liver. And sometimes we rely on the liver for drugs to work or for drugs to be eliminated. And so if your liver function is decreasing, the way the medicine works in your body will be different than what we normally expect or different than how it acted before. Kidney function. This should maybe be something you've heard before. We talk about kidneys a lot when we talk about older adults, especially with medicines. So what I found really interesting is that once you reach the age of 50, the function of your kidney declines by about 1% every year. So it's something that all doctors are keeping an eye on for the most part, but especially when you're on different medicines, many medicines rely on your kidneys in order to work appropriately or to get them out of your body. And so if we know your kidneys are decreasing in function, it's important to keep an eye on that. So this slide, normal changes of aging or medication side effect. There are a lot of things down in this purple circle at the bottom that often we say, oh, I'm falling more, or I'm more confused, or poor memory, urinary incontinence, I'm having constipation or heartburn. Those are just signs of getting older, right? Not necessarily. Some medicines can cause side effects like this that may be perceived as a normal part of aging. So falling as you get older is not necessarily normal. There are other things that could be contributing, and one of the big things that could be contributing is medications. So it's important that we take a look at those. I want you to keep this in mind as we move forward as well. Individualization is key. So every patient has different goals of care and different priorities. The things we're talking about today, and when I list a medicine, it's not necessarily a one-size-fits-all approach. So one person's diabetes is not the same as another person's diabetes. One person's blood pressure and medicines they need is going to be very different than another. So often folks like to talk with their friends about this sort of a thing, and it's important to keep in mind that every patient is different, and we're always going to be weighing the pros and cons. And that's why you need to always be keeping an open dialogue with your healthcare provider so that they are individualizing care for you. So next, we're going to talk about the AGS, or American Geriatric Society, Beers criteria. So a little background information. What is the Beers criteria? Essentially, put simply, it's a list of certain medicines that may not be the safest or most appropriate options for older adults. So a couple of keywords there. May not be. I'm not saying they are not safe. They may not be the safest or may not be the most appropriate. This is not a do not take list. So just because you might see one of your medicines on here doesn't mean you need to stop it, or doesn't mean that it's not right for you. But there are things that should raise some flags for your doctor, that sort of a thing. It's a list of medicines that may be potentially inappropriate for older adults. But again, there are a lot of caveats and different rationales that accompany this list. I'm just going to try and simplify it down if we can, just to give you some talking points or things that might put a light bulb in your head as we move forward. So this is the famed Dr. Beers over on the right. So as far as we know, he was not a brewmaster or a beer lover necessarily, but I'm sure he got those jokes all the time. But he first developed the Beers criteria in 1991. He's got quite a track record. He was the first medical student to do a geriatrics elective at Harvard's Division on Aging. So he's quite educated. And he also completed a geriatrics fellowship at Harvard. So his focus was working with older adults, specifically with medication. So he devised this list. And the goal of the initial list or criteria was to decrease inappropriate prescribing, so have providers and prescribers using this list, but also decreasing adverse drug events, those ADEs that we talked about earlier. So he developed this list and adjusted it as time went on, but in 2001, he passed away. And so that's when the American Geriatric Society took over the revisions and updates. So every 3 years, they get an expert panel together to review thousands of studies, compile all of their findings and put it into a much shorter paper. But the reason for the title of this presentation, you might have caught, is that this panel included doctors, pharmacists, and nurses. As far as we know, they don't actually walk into a bar, but they do meet regularly for years. So for the last update in 2019, they met regularly from February in 2016 until May of 2018. So they probably met a couple times in a bar after the fact. If you're having that many regular meetings with folks, you might need it. But this panel is really putting in a great deal of effort to make sure that every piece of literature and every new drug and all of the studies that come out are reviewed specifically to see how it will affect or impact our older adults. So why does it matter to you? I mean, I talked about it a little bit, that this is a great tool for prescribers to use, but why does it apply to you? So the Beers criteria contains 5 different tables or lists of medicines to avoid or medicines to use with caution in certain older adult patient populations. So sometimes people think of these as 5 beers on tap, or the 5 different tables that you want to look at, and they all apply to different people. So the first table is medicines that you should be avoided by most older people. There's also a table of medicines to avoid by older people with specific health conditions. So a medicine that could be safe for most people, but if you have, let's say, a certain heart condition or Parkinson's disease, you might not want to use that medicine. There's a table of medicines to avoid in combination with other treatments, because there's risk of harmful, what we call drug-drug interactions, where a drug by itself could be fine, but when you combine it with another particular drug, there's some possible interactions. The next table is medicines to use with caution. So there's potential for harmful side effects. And then the 5th table is medicines that we need to dose differently or avoid in people with reduced kidney function. And so I know we talked about how after age 50, everyone's kidney function starts to decline. We do have certain markers as well. So it's not just once it's a little bit down from your normal. It's once it's significantly lower at a threshold that healthcare providers deem to be more concerning. That's when we'd want to keep an eye on those medicines. So why does it matter to you? If you are an older adult with a health condition who is on other medicines and or your kidney function is declining, some of the medicines on the Beers criteria could likely apply to you. Again, I have to throw this out there. This is not a one-size-fits-all. Every recommendation should be evaluated and individualized for each patient. These are all potentially inappropriate medicines, potentially. So the list of resources, it's not a replacement for a chat with your healthcare provider or a chat with your doctor. This is just to give you a little bit more education and more information so you feel more empowered talking to your doctor about concerns that you might have. All right, so next we'll look at some examples of medicines that are on the Beers list. So I've underlined examples here. I want to lay this out. If I were to list every medicine on this in the Beers criteria, along with the rationale, along with their reasoning, it would take us more than the full hour. So what I'm doing here is I found medicines that are more commonly prescribed, or there may be what we call a class of medicines. So for example, it may say antidepressants in a certain category. That does not mean all antidepressants. And just because I only list 2 or 3 doesn't mean those are the only 2 or 3. But again, it will give you an idea of what things you might want to look into a little more, or what things to mention to your doctor if you have concerns. So in order to try to be as thorough as possible without overwhelming you, these are just some examples as we move along. And again, some of these lists or slides might feel a little bit overwhelming, but we'll certainly are more than happy to send these slides out to you after the presentation so that you can review it again. So if we're going through it and it feels overwhelming, or you can't remember if one of those medicines is something that's on your list or not, you'll be able to reference this later, and we'll hand out my contact info as well if you had a question for it. So the first thing we'll look at is commonly prescribed medicines that are, again, potentially inappropriate for use in most older adults. So when we say older adults, generally we're thinking age 65 and older. But I also need to keep in mind, you know, we have, there's such a thing maybe unofficially as a young 70-year-old or an older 50-year-old. So depending on your health conditions and things like that, you may fall in or out of these categories as your doctor would deem appropriate or not. But when we're talking about things like your kidney function or liver function, which even if you're healthy as a horse, those things can still be affected. That's why we keep that 65 as our general cutoff. So the first thing we'll talk about are things called antihistamines, specifically what we call our first generation. So antihistamines we often think of as like an allergy medicine, or a big one you'll hear is Benadryl. And so I have that in bold. If anything you see in this presentation that's a drug name is bold as we move forward, that means it's available over the counter. So when I say over the counter, that means without a prescription, you don't have to talk to your doctor about it. You can just go pick it up at the shelf at the pharmacy. And so the reason I want those to be bold, so you're a little more aware, is you don't have to have a prescriber or a healthcare professional look over your medicines or help you with that. You could just go grab it. But knowing that, oh, grabbing that Benadryl could be potentially inappropriate is something to keep in mind. So Benadryl, another one is Doxylamine, which might not sound that familiar to many, but it's in a lot of our nighttime cold and flu medicines. So if you ever see something that says Vicks or Robitussin, even our Corticidin HBP, which is the high blood pressure cough and cold medicine, that could have something called Doxylamine in it. So it's always important that you're looking at those ingredient lists when you have those combination cough, cold, flu products. There could be some medicines in there that are potentially inappropriate. Hydroxyzine is another one. Meclizine, which comes in our Dramamine, even though it says less drowsy. The reason these antihistamines are concerning is that it can make you feel a little drowsy or dizzy, increase your risk for falls, which increases your risk for bone breaks or fractures. Promethazine is another one, which is often found in combination with codeine as a prescription cough medicine. So when I put the name in parentheses right next to the other one, one's a generic, one's a brand name. So they're the same thing, but you might know it or see it as something else. So these are things that could be inappropriate for most older adults. When we look at different cardiac or heart medicines, if we are using alpha blockers to treat high blood pressure, so doxyzine, prazosin, or terazosin, there's some concern. But again, I told you there are many caveats with this list. Alpha blockers in general are not necessarily the concern. It's alpha blockers if it's your primary treatment for high blood pressure. So this is just one example of why it's really important that we don't take this medicine and say, oh no, I can't take it. You always need to talk to your doctor or your prescriber about it. A class of medicines called alpha agonists. So some examples here, clonidine, methyl-dopa, reserpine, those could be potentially inappropriate. Same with digoxin. Digoxin, but only if it's used as the first thing we use to treat atrial fibrillation or heart failure. So if you do use digoxin, it's really important that we're monitoring the dose closely. Nifedipine is another one, but again, only if it's immediate release. If you're on extended release nifedipine, it's not as concerning. And lastly, for heart medicines is amiodarone. But again, only if it's used as the first thing to treat atrial fibrillation. So this is just a taste of how there are so many different caveats that go along with it, but I wanted to present it this way so that you could see a medicine and say, oh, is that something I want to talk to my doctor about? Or is there a concern there for me or not? Next are medicines that affect your central nervous system, your CNS, so your brain. First, again, antidepressants. How I said before, these are just a few of the primary examples. So there are other medicines that fall under the antidepressant category that are not potentially inappropriate, that are perfectly fine. But the big ones that are most commonly used would be amitriptyline or nortriptyline or paroxetine. Benzodiazepines. These will come up a lot as we move forward. So I want you to tune in on this for a moment. So benzodiazepines. These are often used for anxiety, sometimes for sleep, which is not exactly an appropriate way to use them, but they work really quickly and they help you feel relaxed. So sometimes that helps folks with sleeping. But for most older adults, we need to be really careful with using benzodiazepines because of some of the risks of how it affects that population. The main ones you may have heard of are alprazolam or Xanax, lorazepam or Ativan, clonazepam, also called Klonopin, or diazepam, also called Valium. So benzodiazepines will come up quite a bit moving forward as well. Next is antipsychotics. So if we're treating schizophrenia or bipolar disorder, antipsychotics are appropriate. But if we're using it for other things, maybe someone's agitated or something like that, it might not be the most appropriate medicine. So that would be Haldol, Abilify, Latuda, Zyprexa, Seroquel. I know there's a lot of big names there, but if you're on it or you know the name of the medicine, it would sound familiar to you. And then the last, under the central nervous system, we call them Z drugs. So these are our sleep aid drugs, like Zolpidem or Ambien or Sonata. So we're always a little bit concerned with sleep medicines. And again, it doesn't mean that you shouldn't take it. It just means your doctor needs to make sure to weigh the pros and cons and talk through that with you. Next, we'll look at medicines that affect your endocrine system. So endocrine just means hormones in your body. So your testosterone and estrogen and insulin, those are all big hormones we think about. So testosterone is a medicine that could be potentially inappropriate for most older adults, unless it's someone with confirmed hypogonadism as a diagnosis. Estrogens are also concerning, but there's some caveats. We want to avoid what we call systemic or oral, where you take it by mouth and it goes everywhere in your body. That's the thing we want to avoid. The thing that is usually more acceptable is if it's a topical or a local, like a vaginal cream or tablet, so it only works in the place where you put it. Then it's more acceptable, especially in a low dose, is safer. Now, this could cause a few big eyes or concerns, but I'm going to say sliding scale insulin. So that does not mean that insulin is inappropriate for older adults. Our concern is if you're dosing only a rapid acting or fast acting insulin based on your blood sugar, but you don't use any long acting insulin too. So if you're just using like Humalog or Novolog, but you don't have a long thing like Lantus or Levemir, that's where our concern comes in. And then the last one is a diabetes class of medicines called sulfonylureas, glyburide or glimepiride. And the reason that these two classes, the sulfonylureas and sliding scale insulin, are there is that they can cause a big drop in blood sugar. And so if you have diabetes, a low blood sugar could actually be a lot more concerning right now than a high blood sugar for a long period of time, because the low blood sugar is what could cause you to lose consciousness or have a seizure or that sort of a thing in a really serious instance. So we want to prevent extremely low blood sugars if we can. We next will look at some medicines for your GI tract or your gastrointestinal. So metoclopramide is one that we want to avoid long-term use especially. And then proton pump inhibitors. And here you're going to see all of these are bold, so they are available over the counter. Things like omeprazole or Prilosec, pantoprazole or Protonix, and esomeprazole or Nexium. These can be concerning in our older adult population, especially long-term. So keep an eye on those. They are very common medicines though. So again, this warrants a conversation with the doctor about why you're on it and if we weighed the pros and cons. Pain medicines. This is really tough because a lot of times as we age, pain increases. And often with that comes pain medication. So when I say NSAIDs, that is non-steroidal anti-inflammatory drugs. Things like aspirin, naproxen, which is Aleve, ibuprofen, like Advil, diclofenac, or meloxicam. So it does not mean you cannot ever use them, but the thing that we're most concerned about is avoiding chronic use. because when you use it every day or multiple times a day, then it can lead to more problems with your kidneys as well. It can also increase your risk of a bleed, so like bleeding in your stomach or an ulcer. And then often the way we treat that is with a proton pump inhibitor, which is also on this list. So it adds to a little bit of confusion there and some complexity. And then muscle relaxants. So these are things like cyclobenzaprine or Flexeril, methylcarbamol or Robaxin. Again, those can make you feel a little drowsy or dizzy. And if you're already a little unsteady on your feet, that can lead to more falls or frailty looking things and can be a little concerning. All right, I know that was a lot. The next few lists are much shorter, but the reason that one was a little more robust is that those are the ones that impact most older adults. And so that's usually our general population at these talks. So wanted to make sure that we talked about those in a little more detail. But the next thing we'll look at, these are medicines that are potentially inappropriate, but only if you have certain medical conditions. So if you have heart failure, we're a little more concerned about things like diltiazem and verapamil, and especially concerned about NSAIDs. So we just talked about NSAIDs for everyone, but if you also have heart failure, it should raise a second flag for you. If you or a family member has delirium, we need to be especially concerned with the antipsychotics that we talked about previously, our benzodiazepines, corticosteroids, and what we call H2RAs. And these are often used for like heartburn or things like that. Things like famotidine or Pepcid or Zantac, which is available over the counter. So again, keep an eye on those. The reason that we're concerned with delirium, it can sometimes make the symptoms of delirium worse. So we want to keep an eye on that. If you or a loved one has dementia or cognitive impairment, we are especially concerned about those benzodiazepines and antipsychotics. And again, if you're like, oh, which ones are those? We'll give you that list, the slides, and the list was on a previous slide for you. If you have a history of falls or fractures, there are some certain medicines that can potentiate that and make it worse, make you more likely to have another fall, which could lead to another fracture. The first is things like anti-epileptics, and those are medicines that are used for seizures, but we can use them for other things. So just because you don't have seizures doesn't mean you're not necessarily on or not on an anti-epileptic. You're going to see these come up a lot, these antipsychotics and benzodiazepines. I know I probably sound like I'm talking a foreign language to some of you, but again, you'll have these references to go back. Falls and fractures, we're more concerned with multiple types of antidepressants. So for the general population, there's only a handful that we're concerned about. But if you have a history of falls, we're more concerned about a larger array of the antidepressants. So that's when you'd want to talk with your doctor more. And opioids. I feel like opioids are kind of a hot topic these days. Things like codeine, hydrocodone, oxycodone, or morphine, those are our heavy-hitting pain medicines. They can make you drowsy or dizzy. They make you feel a little bit loopy, and that can lead to more falls, so we're more concerned. If you have Parkinson's disease, there are some antiemetics or anti-nausea medicines here, like metoclopramide or promethazine that we're concerned about, and then those antipsychotics. If you have a history of ulcers, we need to be cautious with how much aspirin you take per day and how often or chronically you're using those NSAIDs like Advil. With chronic kidney disease, so chronic kidney disease is different than just a slight decline in kidney function. Chronic kidney disease is a diagnosis where you reach a much lower threshold than some of our other things or our other markers of kidney function. But that's when we really want to be careful with our NSAIDs, so our Aleve and our ibuprofen. And for women with urinary incontinence, we want to keep an extra eye on estrogen, doxylamine, prazosin, terazosin. So if you looked at some of these lists and you said, I don't have any of those conditions, these don't apply to you. Or if you look at this list and you say, oh, I do have urinary incontinence, but I'm not on any of these medicines, that's how I want you to kind of approach this. Next are ones that we are especially concerned about with kidney function. So there are a couple of antibiotics, our ciprofloxacin and Bactrim. that we would want to be more concerned. That doesn't mean you cannot take them. It just means we'd need to make sure the dose is adjusted. And the good thing about the way our healthcare system works, you've got a prescriber who's keeping an eye on it and a pharmacist who fills it that's got an extra eye on it to make sure those doses are appropriate. But especially if you know your kidney function has changed or your doctor mentions that, it's always good to keep an eye on it or mention it to your healthcare team. Next is our central nervous system or pain medicines. So these are ones with needing to be adjusted for kidney function. Cymbalta, gabapentin is a pretty common one we see, especially in nerve pain or folks with diabetes. Keppra is a medicine that we often use for seizures, but it can be used for pain as well. Lyrica and tramadol. So if your kidneys aren't working as well, we want to adjust or maybe stop some of those medicines. And then the list of cardiovascular medicines. Most of these are blood thinners, not like warfarin. They work a little bit differently. But Lovenoxes and injections, Xarelto, Eliquis, and Pradaxa are more common ones. Excuse me. And then famotidine and ranitidine are both available over the counter. And those are things we need to be careful about with your kidney function. So again, just because it's available at the pharmacy without talking to anyone doesn't necessarily mean it's appropriate. So this is a bonus table. You may have heard of something called anticholinergic medicines or medicines with anticholinergic properties. Anticholinergic properties are essentially a list of some side effects. So things like urinary retention or dry mouth might make you feel a little dizzy, things like that. So if we have multiple medicines that all share that similar side effect profile, we want to be careful not to use a lot of them together. So this next list, if you're on one or two of these medicines, not a huge concern. But if you notice that there's 4 or 5 of them on here that are on your medicine list, that's when we're more concerned because we don't want to pile them all together and make all those side effects worse. I think of it almost like if you've got different types of spice in your food. You don't want to necessarily have wasabi and red pepper and some jalapenos with your meal. It's all too much, but 1 or 2 of them at a time is probably okay. So some of the antidepressants that have more anticholinergic properties are amitriptyline, nortriptyline, and Paxil. Some anti-nausea medicines we already talked about. Some antihistamines are our big ones, like our Benadryl and Dramamine less drowsy, the Meclizine. Some medicines for urinary incontinence. So the way those work is by trying to prevent you from releasing urine when you don't want to, but that is also an anticholinergic side effect. So it may be helpful, but could be harmful when combined with some of these other medicines. Clozapine or olanzapine are some of the antipsychotics we're concerned about, atropine, belladonna, and scopolamine, and then Flexeril, which is a muscle relaxant. So if you look at this list, you're like, oh, one of those sounds familiar, not too concerning. But if you look at it and you say, oh, I'm on 3 or 4 of those medicines, that's where we're concerned. All right, that was a lot of information. I'm going to simplify it and I'm going to give you some more action items. So you might be sitting here saying, I am overwhelmed by all that gibberish she just talked at me, but here's the simplification, okay? Medicines you want to pay close attention to, things that affect your brain function. So our anticholinergics, that list we just looked at, the benzodiazepines like Xanax, lorazepam, things for anxiety or real quick acting for sleep. Our sedatives, so things that make you sleepy, or Z drugs, which are our sleep medicines like Ambien, and antipsychotics. NSAIDs, you might notice that came up quite a bit. The reason is we want to avoid long-term use whenever we can. So Advil, Motrin, Aleve. Muscle relaxants, medicines for blood pressure, which I don't want you to be alarmed there because a lot of folks are on blood pressure medicines. The reason we're concerned, we just don't want to lower your blood pressure too much because that could be have some detrimental side effects. Blood sugar medicines, so diabetes. For the most part, we're okay. We just don't want to lower your blood sugar too much. Some antidepressants, any over-the-counter medicines that say PM or sleep on them, and then estrogen. So these are the ones that kind of are big few that you want to keep an eye on. At this point, I'm going to pause for questions in case anything has come up that needs addressing. Has there been anything, Savannah, that?
Yes, we do have two questions.
Okay.
So Maureen would like to know, are there liver checks that are routinely done as well as those for kidney function?
Great question. Yeah, so when you get your blood drawn from the doctor, usually at least once a year, they'll do an overall look. And kidney function is commonly drawn for almost everyone, and liver is a pretty common one too. The liver checks that they'll look at is called your AST or your ALT. We call those your liver function tests. So yes, those are checked regularly. And then for your kidneys, we check something called creatinine, or we then do a calculation to find your creatinine clearance. So creatinine is something that floats around in your blood, and your kidney's job is to clean or filter your blood. I think of your kidney kind of like a coffee filter. So all of your blood goes through your kidney, and that coffee filter collects excuse me, any waste or trash that we want to get rid of. It also will collect the stuff that's still good that we want to keep in the body. And then the rest of it just kind of flows through and comes out through the urine from your kidneys. So creatinine is one of those things that floats around in your body. And if we can measure how much creatinine there is or how quickly that creatinine gets cleared out of your body, that gives us a good idea of how well your kidneys work. So yes, if you are seeing a prescriber or physician or primary care provider regularly, they should be checking those things for you. So usually, if no one's brought it up to you, if you've had blood work done and no one said anything, you could hopefully assume that most things are okay, but it's always a good idea to ask. But again, if you're not sure, the things we look for are AST and ALT for your liver, and creatinine or creatinine clearance for your kidneys. Yeah.
Then we have another question from Dale. When we fill prescriptions at the pharmacy, is it likely that the pharmacist will flag any of these drugs as potentially inappropriate for us?
That is a great question. Yes. So the few things to keep in mind though. So pharmacists have lots of different tools and things like that that do automatic checks. And before a prescription can leave the pharmacy, the pharmacist has to look at it, make sure it's the right drug and all of that. But they also compare it to your medication list to see if there's any interactions, which was one of the things we're concerned about in older adults. But let's say you fill your medicines at different pharmacies, or let's say you got a sample from the doctor, or let's say you pick something up from the shelf. The pharmacist won't be able to compare those. So that's why communication is important. The other thing is they always will have your age on there, and most pharmacists should be aware that if a drug that's on one of these lists comes up and they see the patient's age, they should flag it and discuss it. They might not discuss it with you. They may reach out to the doctor and say, hey, you know this medicine's on the Beers criteria. Did you weigh the pros and cons? So a lot of times pharmacists are having those discussions on the back end. But one thing we're going to talk about here is reviewing your medicines with a healthcare provider, maybe asking if it's a new medicine, hey, is this someone that's safe? Is this a medicine safe for someone my age? Is this a medicine that's safe for someone with my kidney function? That sort of thing. So the pharmacist isn't necessarily going to have access to your kidney function, but the things they can check are, does it interact with your other medicines, if they know what those are? And then is there potentially an appropriate medicine given your age? So this is something that is always at the front of the pharmacist's mind. Good question.
And then one last question we have from Donna is, what about taking daily 81 milligrams of aspirin?
Good question. Yes, so that is different. One thing you'll see in a couple of those lists, it said aspirin if it's over a certain dose, so like over 325 a day. We also get a little more concerned with aspirin as you age more. So when you're over 75, taking that, what we call a baby aspirin, the 81 milligrams, needs to be weighed again with your doctor. So 81 milligram aspirin for most folks, depending on your other conditions and what we're trying to prevent, is generally appropriate. But once you reach that threshold of 75, it's important to have that conversation with your doctor again. But when we talk about chronic use of NSAIDs, we're saying Aleve or Advil for a headache, every day or 3 times a week or something like that. But a low dose aspirin is not as concerning. So the 81 or the 325 is generally safe. Again, I can't speak to each individual patient's concerns, but generally safe. But when we get over that amount or you're taking more than that, it should be a conversation to have with the doctor. Great questions. Yeah.
Great, and that looks like the end of the questions that we have so far.
Awesome, let's keep going then. So here's our action items. What can you do? First, do not stop any of your medicines without checking with a healthcare professional first. So just because you saw this list, I'm not trying to raise alarm. Always talk to your doctor first. So what can I do about adverse drug events? Remember that with each added medicine, your chance of an ADE increases. So when a medicine needs to be added, don't be afraid to ask questions, especially if it was a medicine that you saw on one of these lists today. But what questions do I need to ask, right? Whenever a new medicine is started, I think these are important things to think about. What's the purpose and what are the benefits of the medicine? What's the harm if I don't take it? How do I know if it's working? What side effects should I watch for? Will this interact with other medicines that I'm taking? Will it affect any other of my medical conditions? Are there any alternatives? And beware that alternatives could be another prescription. Alternatives could be an over-the-counter medicine. Alternatives could be like, we don't want you on this benzodiazepine for sleep. Let's talk about your at-home actions or sleep hygiene. So it might not be what you want to hear, but if you're asking for alternatives or you're worried, just know that that's what could be coming. It's important to regularly review all of the medicines that you take with a healthcare professional, whether it's your prescriber, your pharmacist, they're always there to help. So ask if there are any drug interactions, ask if there are any unnecessary medicines. And as I mentioned before, remind them to consider your age when reviewing. There are times where someone could come up to the counter and I'm guessing they're 50 years old, but they could be 70. Or you would guess that someone's 70, but they're actually 50. So it's always a good idea to remind someone, hey, if you're over 65, make sure you consider my age when you look at these. And keep an eye out for some of these medicines we talked about. Do not be afraid to ask for alternatives. So everyone's probably heard you should have a medicine list. You might have a little list in your wallet, or sometimes it's a good idea to keep it on your phone if you have a smartphone in like a note or something, or take a picture of it on your phone so you always have it with you. Update that list regularly. So every time you go to the doctor, every time you pick something up from the pharmacy or from the aisles in the pharmacy, add it to your list. Anything you ingest, inject, inhale, or apply to your body goes on that list, whether it's a prescription or not. So it's not just the things you swallow, but don't forget your vitamins and natural medicines or herbal products. And don't forget your devices. People often forget inhalers or nasal sprays or topical lotions or things like that. So I don't need to know about your moisturizer, but I do need to know about your steroid cream. And then in this purple box, this is a really great tool. For every medicine on your list, include the name of the drug, the strength, so how many milligrams, how many units, the formulation, so is it a tablet or a liquid or a patch or an injection, how many you take at a time, and how often you take it. So if you just say, I'm on metoprolol, doesn't give me a whole lot of information. If you say I'm on metoprolol 50, that's better, but do you take 1 tablet? Do you take 2 tablets? Do you take 2 twice a day? There's a lot more that needs to go into that. So make sure your medicine list is complete and share it with your providers. Make sure every doctor knows every medicine you're taking. So don't assume that they talk to each other. Don't assume that they saw or realized any recent changes to your medicine. Don't be afraid to share that medicine list, especially if there are changes. So how do I talk to my prescriber or healthcare team about my medicines? Maybe you saw a medicine today that raised a flag for you, or you saw a health condition I mentioned and you're like, oh, I have that. I wonder if any of my medicines are concerning. How do you talk to your doctor about it? First, when do you talk to your doctor? If you're concerned about a medicine. So maybe you think it's not working, maybe you're having a side effect, maybe it was on one of the lists that we reviewed today. Those are good times to bring it up with your doctor. Questions to ask if you have a concern. Is this safe for someone my age? Is this safe for someone with my health condition, especially, with my kidney function or with my heart disease? Is this safe with the other medicines I'm taking? For the most part, these are things that your pharmacist and your provider are going to review, but it doesn't hurt for you to bring it up again. It also can give you some peace of mind and say, I asked specifically about my kidney function with this drug, I'm good to go. Ask if there are possible alternatives that could work for you. So just because it's on this list doesn't mean you can't take it. It may still be the right medicine for you. Your doctor weighed the pros and cons, and this is what's best for you. We talked about this a little. Possible alternatives could be another prescription, an over-the-counter medicine, that sort of thing. So just be aware of that. Remember, all of the medicines and medical care choices are meant to be individualized. So it might be safe for your friend to take a medicine that was on the beers list, and it might be unsafe for you to take a medicine that's on the beers list, and that's okay. People respond differently to medicines, and your prescriber is the one who's going to weigh those risks and benefits and should help you and give you their rationale. This might feel a little mushy for some people, but it's important to let your prescriber know how you feel about your medicines. Let them know what's important to you. So questions to ask yourself to know, how do I feel about my medicines, right? Are you concerned with the number of medicines you take? Is it hard for you to remember or to take them or to keep track of all of them? Like, let's say I'm really good with breakfast and dinner, but I always miss my lunchtime dose. That's something to share with your doctor. Are there any medicines that are really important to you? And if so, what are they and why? And what is the main reason that you take your medicine? Do you just think that you have to? Does your family say you have to? Do you know, this is how it works and it's going to help me, so I should take it? But think about that and talk to your doctor about it. Think about how your family or your loved ones close to you feel about your medicines. So, maybe Great Aunt Susan doesn't necessarily know what's best for me, but my spouse or my children might keep a better eye and have some concerns if they think my medicines are important. Do they think I'm on too many? Do they think I'm on something that I shouldn't be? Or I should be on something that I'm not? Are you worried about the financial cost of your medicines? Bring that up with your doctor. And then, are there any medicines that are a burden to you? So whether it's difficult to take it, they're hard to swallow, you can't use the device, the pharmacy never has it in stock, bring those things up with your doctor. And then lastly, just some resources for you. The most important one I want you to remember is healthinaging.org. So all one word, healthinaging.org. This one has a lot of patient-friendly information on a bunch of different diseases and diagnoses. There's information on age-friendly healthcare and some patient resources about preventing diseases, nutrition, physical activity, all focused on older adults. So it's a great resource. And then the National Council on Aging has some other resources available about healthy living. It may link you back over to Health in Aging, but I wanted to make sure that those were available for you. And it'll talk through also some medicines and Beers criteria in a different way than maybe I did. That could also be helpful. So with that, I will take any additional questions if anything else came up throughout the presentation.
We did have one more question pop up in the chat from Barbara.
Great.
And she says, I am 80 and have fibromyalgia. I was just prescribed gabapentin.
Yeah.
You might have to correct me on that one. After reading about the drug, I was reluctant to take it. What do you think?
So that's a great question. It's difficult sometimes when I don't have the full picture, but I know fibromyalgia is a pretty difficult, involved disease to treat sometimes. And so gabapentin is commonly used. The things that we're more concerned about with gabapentin is keeping an eye on your kidney function and making sure that the doctor talked to you about the pros and cons, talked to you about the side effects, and weighed any alternatives. With fibromyalgia, for those who aren't aware, it's a, simply put, it's chronic pain, which can often be quite debilitating, and we can't figure out necessarily where the source of the pain is. There are plenty of older adults that take gabapentin and do so safely. But if you do have concerns, that's where I would just talk to your doctor about it and say, hey, did we make sure my kidney function's okay? Is this safe for someone my age? Express your concerns to your doctor. As unfortunately, since I can't look at like every diagnosis or every medicine you're on, I don't feel safe or comfortable giving a definitive yes or no, but know that there are plenty of folks who take it and it is safe. But there may be a couple of instances where if something changes, you want to let your doctor know so that they can then weigh whether or not that medicine's worth it for you. But especially if it's helping, that's one of the big pros that we often look for. So good question. And I'm sorry that I couldn't give you a definite yes or definite no, which is often what we're looking for there. But hopefully some of those later slides gave you an idea of how to talk to your doctor about it if you do have more concerns.
Great. Well, thank you so much, Abby. That looks like that's the end of the questions for right now. But we really appreciate your time and all the information that you shared. I will be sending out copies of all these slides as well as your contact information. And we'll also include a short survey we'd like to have everyone fill out so we can hear about your experience on the Zoom event today, what worked well, what we could improve on just to make it the best experience possible for everyone. But if you would like to get in touch with us here at University House, you can either reply to the email we'll be sending you, or you can give us a phone call. Our phone number here is 425-557-4200. And thank you so much, Abby. Was there anything else you wanted to add before we go today?
I just wanted to thank everyone for tuning in. I know it's an unconventional way of doing this, but it's really great that we're still able to connect like this. And I appreciate your attention and also bearing with my few technical difficulties and going a little bit over time, but I really do appreciate you guys tuning in. So thank you.
All right. Well, thank you so much, Abby, and everybody else. I hope you have a wonderful rest of your day. Please feel free to get in contact with us or Abby after we send you her contact information. All right. Bye.
Bye.